And welcome to tonight's webinar. Good to have you with us. We're really happy to have as our guest an icon in periodontics, and that's Dr. P.D. Miller. And he's been so kind to me over the past few months. So let me tell you a little bit about how P.D. and I got together, because we had never met each other. As all of us growing up in the profession, I've seen P.D. on the podium, but he and I had never spoken. So most of you know that I like to write on AP Connect, and that's how many of you met me. So I wrote on AP Connect, and we're talking not about dental implants. We're talking about something that I had done years and years ago, where I had stated that for 1 year, I would do no periodontal surgery. I would only do non-surgical periodontics. This was in the late 80s. And I did it because I wanted to have the opportunity to observe what non-surgical periodontics is all about. And so we did a technique that was developed by Perry Ratliff years and years ago, where we packed cords, just like we pack cords around the gingiva to do gingival retraction, and then we would replane. And we did that, and these cords were impregnated with a couple of chemicals, like any difference. And I wrote that, and the deal I made with the patient was, every patient, I said, I'm going to charge you my regular fees. We're going to do non-surgical treatment. And if you need surgery, I'll do the surgery at no charge. Now, of course, if the patient had an abscess, something like that, of course, we're going to do surgery. But I'm talking about chronic periodontitis. That gave me the opportunity to really observe what healing was all about without my doing anything to change the gingival tissues, at least not cut away the gingival tissues. And I learned an awful lot during that year. So I wrote about that. And PD happened to pick that up or see it, and he called me. And at that point, he introduced me to the MMPPI. Since that time, PD has trained my staff in the MMPPI. He got up at 5:30 in the morning, Central Time, because my staff meetings are 6:30 in the morning. And he trained my staff how to use this index. And I got to tell you, this index has made a tremendous difference. The first time, now the MMPPI essentially gives the patient the opportunity of understanding what his or her prognosis is in treatment of periodontitis, chronic periodontitis. Not only that, it also shows the patient what his or her responsibility is in treating chronic periodontitis and how he or she can improve the prognosis. It's a simple index, and you'll see that in a moment. It's something that empowers our assistants, because our assistants have every opportunity then to instruct the patient. And as you know, I want my assistant to be in charge of the case, not me. I want the patient to look at the assistant as a resource. And this essentially adds a very quick scoring method and a very easy resource to allow a patient to understand what the periodontal prognosis is all about and whether it's worth having periodontal treatment or not. So PD trained my staff at 5:30 in the morning. Now he's training you at his time, 7 at night, 8 p.m. Eastern time. So PD, thanks for being with us on the IDS webinar.
Thank you, my friend. And would you share with them that you used the MMPPI that very first day on a patient who was coming in for an all-on-4, and tell them about what happened the first case you did that on?
That's exactly right. And it was the first case we did it on. So the patient comes in and says, I hear you take out those teeth and put in them implants, and that's what I want. And I said, all right, let's look at it from both perspectives, which we do. As you know, we're going to do a lot of implants just by telling people that we can save teeth. And that's how we differentiate ourselves as a periodontist, you already know. So anyway, we did the complete periodontal examination. I used PD's index. And I really felt in my heart that extracting the teeth was not the right thing to do. That saving the teeth and doing appropriate crown and bridge, appropriate periodontal treatment and crown and bridge was really the better way of going. So I did that. I did the scoring. I did the scoring method. Or actually, my assistant did it based on the parameters that you'll see in just a moment. I told the patient my opinion. I said, you can look at it either way. But here are the advantages of saving your teeth. Here are the advantages, and I don't think there are as many advantages to take out the teeth. But go ahead and talk it over with my assistant to decide what you want to do. So after we got done with the examination, the patient went for financial arrangements to talk about the different options. And as you know, I think that needs to be a long visit because I want the patient to fully understand what's going on. The patient ended up accepting treatment, not accepting treatment for the extractions and hybrid. It was to save the teeth, do appropriate periodontal treatment, and crown and bridge. Now, and so I called PD. I said, "This worked fantastic." And PD said, "Yeah, and I bet you saved the patient a lot of money too." I said, "No, as a matter of fact, the restorative plan actually cost more, $7,000 more than the dental implant plan." So with that, that was the first step out of the box. And since that time, every periodontal patient who comes in gets scored, gets an index, and has a good idea, a better understanding as to what periodontal treatment can be done. By the way, PD, what I didn't mention is that essentially what PD did was to go over all of his records over 40 years and took patients that he had treated and looked at all of these parameters and saw his success in treatment. So we're not talking about a laboratory exercise. We're not talking about hocus pocus. We're actually talking about hard and fast data and by a good periodontist. And as long as a good periodontist is treating the patient, then you can achieve the same results. So with that, PD, let's
roll it.
What do you want?
Thank you, sir.
Good. So shall we go right to the video? What do you think?
Yes, let's go right to the video.
All right, good. So here's what we're going to do. I'm going to play the video. And as we go through the video, I know there are going to be some questions that I have. There may be some questions that you have. Use the question and answer panel. Just type out the questions. And when it gets to an appropriate time, I'll ask PD the questions. Okay, so you got the question and answer panel probably right at the bottom of your screen. It says Q&A. Just click on that and you can type in the question. Okay, let's go.
I'd like to thank Dr. Lee Sheldon for providing me the opportunity to provide this information to you tonight on the MMPPI, or the Miller-McIntyre Periodontal Prognostic Index, which Dr. Sheldon is using in his practice and will be making some comments as we go along. But the title of it is how the MMPPI can positively impact your practice. It markedly motivates patients to accept treatment, to complete treatment, to comply with the preventive maintenance recommendations, to stop smoking, to better control their blood sugar if they're diabetic, to initiate lifestyle changes, and to create patient referrals. You can trust the MMPPI because it is evidence-based, it is statistically validated, it's very accurate, and it has been published in the February issue of the Journal of Periodontology, and it has been validated. So here's the article that was published in the Journal of Periodontology in February 2014, an evidence-based scoring index to determine the periodontal prognosis on molars. And it was validated when it received the Clinical Research Award of the Year in 2015. The AAP has a committee that reviews all of the clinically significant articles published in a given year and only selects one that they feel has the most clinical significance. And this article was selected, and this is me receiving that award. What makes the MMPPI unique? First of all, it is the only index that is quantitative. And why is that important? Because patients want a definitive answer before they elect to select a treatment plan. It's the only index that determines the prognosis at the initial exam, and we'll discuss that in depth. And it's the longest prognosis time in the literature because the patients were in the study a minimum of 15 years. The average patient was in it for almost 25 years, and the teeth extracted during maintenance therapy survived an average of 15.4 years before they were extracted. Now, ladies and gentlemen, that is valuable information to provide for the patient. A brief look at comparative studies. We see the Hirschfield study on the left, which is a classic study, was out 22 years. You look over to the right, under the present study, and we were 24.2 years. We look further down, comparing it to the Danowitz study, which is the only one that dealt just with molars, but this was a period of only 5 years. Ours was 24. But here's what's significant. Look at the percentage of teeth extracted during active treatment. They took out 6.5. We only took out 3.9.
My treatment philosophy at that time was I was willing to attempt to treat any tooth that was functional, regardless of the severity of the periodontal disease.
Other advantages of the MMPPI: it addresses a systemic link, and it points out the importance of a treatment-focused diagnosis, which we will discuss in depth later. It stresses the importance of lifestyle changes, and it shows the impact that periodontal treatment can have on lowering the MMPPI score. You will see in a minute that smoking of the 7 factors was off the wall in being significant. So on my web textbook, P.D. Miller's web textbook, at the bottom, there is a short video about 6 or 8 minutes showing me giving smoking counseling to a patient. Now, whether you want to take the time to do that or not, I would suggest that you look at that because there's some interesting concepts on that. Now, I mentioned that the index was designed to determine the prognosis on molars. However, it can be used to single teeth as well. But the score is going to be better on single teeth because you don't have a molar type and you don't have furcation involvement. So single-rooted teeth, as we all well know, have a much better prognosis than molar teeth. Now, what do you say when a patient asks, if I have this periodontal treatment done, how long can I expect to keep my teeth? Currently, in most practices, well, it all depends on this, it depends on that, it depends on that. Much better to say, well, if you do the keys to success that I'm going to give you, you're going to have a 96% chance of keeping your teeth for 15 years in health, or an 87 or a 65 or whatever. Now, if you're presenting a fee to a patient and say, well, the fee for what I'm going to do for you is going to be somewhere between $500 and $50,000. What is the likelihood of the patient accepting treatment? The same is true of prognosis. When you give them a definitive answer and a numerical answer and a quantitative answer, this goes a long way to motivating the patient. How was the Miller-McIntyre index derived? It was taken from data in my private practice from a complete periodontal exam and case history. Data was collected on 102 patients with 816 molars. And we're going to talk about the criteria for selection, because the criteria for selection was very, very tight. All the patients had to have a diagnosis of moderate to severe chronic periodontitis. Now remember, this study was done in between 1969 and 1994, before many implants were placed. So therefore, patients referred to my practice obviously had a diagnosis of moderate to severe periodontitis because I didn't get gingivitis referrals. But here is the one that really culled most of the patients. The patients had to have 8 first and second molars. They had to have a complete second molar occlusion. And what I found, only about 1 patient in 10 that came to my practice had all of those molars. And so 90% of the cases that I looked at, we were eliminated. And all the patients were a minimum of 15 years post-treatment. And if you go back to the comparative studies, none of them went out that long. Years post-treatment, a minimum of 15.4 years, and the average was 24.2 years. The range was 15 to 40 years. And remember that those teeth lost during maintenance survived for 15.4 years before they were extracted. Now here are the 7 factors that make up the index: age, diabetes, smoking, molar type, probing depth, furcation involvement, and mobility. Remember my philosophy. I treated all patients in depth, regardless of age, if I felt the teeth could be saved.
So even if I had a 25-year-old patient with 9mm pockets, I would treat them in depth. And that included surgical treatment. For if you've got pocket depths of that range, you and I both know you're not going to be able to get the calculus off with non-surgical treatment. And what this resulted in is that patients that were treated in depth ended up having a great prognosis. So therefore, if they were less than 39, they scored a 0, and if they were over 40, we scored a 1. Now we got 0 and 1, but when you actually come to the scoring, rather than place a 0, place a dash, because it's easier to overlook a dash than it is to look at a 0. Diabetes, we're going to discuss a theoretical way of doing that, because we did not have a significant number of diabetics in the study to come up with a statistically validated score. And certainly if they scored less than 6, we weren't concerned about it. A 6.1 to a 7 was a 1 and so forth, because when you get into the 8 and 9mm range, these are where the neurological and vascular changes come that have such a detrimental effect with diabetes. Smoking, as you will find, was the most significant factor, and look at the score on that. They scored a 4. Molar type. Initially, we did not score molar type, but as you will see earlier, the maxillary second molar had the poorest prognosis markedly than other molars. Now, everyone listening to this tape realizes that the maxillary second molar has a poor prognosis when compared with the other molars. So, I arbitrarily decided that it was a maxillary second molar, we would score that a 3. Maxillary first molar, which obviously has a better prognosis than the second, we'd score a 2. And mandibular molars, we would score a 1.
All right, so PD, let's just go over that, because there's a typo in this particular box under molar type.
All right. What we're doing is we're scoring the maxillary second molar a 2, the maxillary first molar a 1, and the mandibular molar, we're scoring a 0 on that because it has the best prognosis.
Okay, thank you.
Yes, sir.
Now, probing depth. When we started this study in the late 1960s, clinical attachment loss was not a commonly used term. We just used probing depth. And anything 5 or less, we think was not significant. And from 5 to 7, we scored a 1, 8 to 10, a 2, or over 10, we scored a 3. Furcation involvement we're going to discuss in depth in a few minutes. And furcation involvement was based on the presence only of a furcation, because I did not plan to do a study or score anything when I did this. I just want to know if a furcation was present. So therefore, a maxillary molar has 3 furcations. A mandibular molar has 2. So therefore, if one of those furcations is involved in the maxillary tooth, it scores a 1. If 2 are involved, a 2. If 3, a 3. And in the mandibular arch, if you have a through and through furcation, we do score that a 2, a 3, even though it only has 2 furcations involved. Now, mobility. I'm going to skip mobility right now because we're going to discuss that in depth in a few minutes. We talked about diabetes mellitus as a prognostic factor, but interestingly enough, only 2 of the 102 patients that I examined and qualified the study gave me a diagnosis of diabetes mellitus. So obviously I did not have adequate data to come up with a statistically validated term. So therefore, we used varying levels of A1C to come up with a score on that. As I said earlier, these are the scores that we determined, and then my colleague, Dr. Gopal, in a recently published study, used those figures, evaluated them statistically, and found that they were valid. So now that we have a statistically validated score for diabetes, and I'd like to thank Dr. Gopal for doing that. But what if you don't have an A1C score? Well, you can use a score of a 2. But I would recommend everyone listening to this tape who is interested in providing the very best service for their patients to consider using an in-office testing case which if you buy by 20, cost about $12 to $15 a patient.
One thing, just because I ordered the test, make sure you order the stylet, or the thing that's going to do the puncture on the finger. That's separate from the A1C now. Very inexpensive, very easy to use. Our entire staff was trained how to use it in less than half an hour.
We talked about the impact of smoking. Patients who smoke compared to patients who don't smoke have a 246% greater chance of losing their teeth. Ladies and gentlemen, that is very significant in motivating patients because they realize that smoking is bad for their lungs, for their heart, and so forth, but they don't know that it impacts their dental health. And whether you want to give smoking counseling, as I've discussed earlier, by looking at my tape on that, or whether you simply want to refer them to 1-800-QUIT-NOW, that is your choice. The decision to treat or extract teeth or place an implant. And this is a study by Ginobili and his colleagues, of very recent studies, and it was interesting, their observation. Younger dentists are not trained to save teeth. Now that's sad, is it not? And the incidence of peri-implant disease ranges from 19 to 65%. So they concluded, we are extracting too many teeth too early, and we need to get back to our roots and start treating periodontal disease. And I'd like to thank Dr. Harold Chaslin for the webinar that he gave in August, and I would suggest that you listen to that because he talks about how these teeth can be restored, and it is a marvelous concept, and I congratulate Howard as well as Danny Melker, who developed the technique, and our host Lee Sheldon tonight, who may want to discuss that in his comments.
Yeah, and let's talk about that now, PD, because you and Howard have gotten together.
Sure, yes.
So let's talk a little bit about the difference. Most of you have seen Howard's webinar. If you haven't, just let me know. Or actually, all you have to do is go to YouTube and type in Howard Chaslin, and his webinar will show right up on top. And we've gotten views. I think it's like over 600 views of that webinar. It was a very popular webinar. And of course, he and Danny talk about how to save teeth, particularly carious teeth, or teeth that have furcation involvement, and the root preparation that you do in order to be able to save those teeth. PD, just give us an impression as to how you feel this fits with the MMPPI.
Well, as you and I have talked, Lee, I think they fit together like a hand in a glove or like scissors, because what I'm showing is what can be done, and Howard is showing how it can be done. So therefore, mine is designed for diagnosis, for encouraging the patient, for getting them involved with saving the teeth and giving them the percentage of success that they can have. Then once they have accepted that, Howard's tapes and technique on the bio-shaping shows how these teeth can be prepared. But unfortunately, in most residency programs, this technique of bio-shaping is not done. So I echo what you've said. You need to look at that tape after you have looked at this, because this will enable you to encourage the patient to have what Howard is showing them how to do.
Very good.
Teeth versus implants. And here's a study by Peterson in 2007. And he reviewed 49 papers and found that with implants, after 10 years of survival, they did not have any better success rate than compared with periodontally compromised natural teeth. How long do teeth survive with furcation involvement? And here's a study that shows the data suggests a high level of tooth retention compared with implant-supported restorations. So it's very obvious that while we all are concerned about furcation, they are not as big a deal as we thought. Now let's talk about mobility. I would mention that earlier. We talk about class 1, class 2, class 3 mobility, but what exactly does that mean? Basically, from a clinical standpoint, a class 1 mobility means that a tooth is slightly mobile and it's loose, but you as a clinician do not feel that that's significant. A class 2 mobility simply means that you are concerned about it. But let's talk about class 2 mobility because it's not always the same. Let's say you've got a 29-year-old patient missing the lower molars and is going to have a lower or mandibular free end saddle partial, which is going to torque those premolars. And in checking the mobility, you find they have some mobility. Well, I'd be concerned about that, so I would score them a 2. But then let's fast forward to a patient that's 75 that has a second molar occlusion, and the bicuspids, in that case, lower bicuspids, could be moved exactly the same amount of the young person. Well, at 75 with a full complement of teeth, everything else being equal, I would score that a 1. A class 3 mobility we typically think of as a hopeless mobility. But let's say that you have a patient who's had orthodontic treatment with significant root resorption that has a gingivitis. Obviously, those teeth can be quite loose, which I would score a 3 because I would be concerned about it. But certainly with a gingivitis and an orthodontic case, I'm not about to take out all those teeth because they're a class 3 mobility. Now let's look at the statistics, and I don't mean this to bore you, but I think this is a very significant factor. We use a multivariable Cox proportional ratio rather than a relative risk ratio. And here you see the scores, and they're color-coded to give you the significance. Those with no color on them, age, mobility, and furcation involvement have the least impact. Certainly probing depth and mobility have a much more significant impact, but look at smoking, a 3.46 or almost a 4. So you can make book on this because this shows that furcation involvements are not near the factor that we think, and using the techniques that Dr. Chaslin showed on that video, we can actually eliminate some furcations. The advantages of the multivariable Cox proportional ratio over the relative risk ratio. If the relative risk ratio were used, teeth extracted during active treatment or during maintenance could not be included in our database. And as you're going to see, that would eliminate a lot of teeth. It would eliminate the 32 molars that were extracted during active treatment. It would eliminate the 145 teeth that were extracted during maintenance therapy. And I would like to emphasize again that these teeth survive a minimum of 15.4 years. So we would have had eliminated 175 teeth, and the statistical data would not be nearly as valid because the larger the sample size, the more accurate the study. So actually 78% or 79% of the teeth survive. But I know what's going through your mind. You're thinking, well, PD's keeping a lot of teeth that really need to come out that are periodontally involved. But let's look at what the American Academy of Periodontology said in a position paper that they published, and that is survival plus as compared with survival in health. Survival in health is characterized by the absence of redness, suppuration, and bleeding on probing. And there's a video on here where I make a difference between a periodontal defect and a periodontal pocket. And I would suggest that you look that up on the web textbook.
Now, PD, let's talk about this a little, because there are things that we're taught. For example, when there's a root proximity problem, or you have a molar, let's say a second molar that has a furcation and a first molar that doesn't, but there's a root proximity problem, and that in fact the disease could spread in some way from the second molar to the first molar, and therefore we need to extract the second molar in order to be able to keep the first molar going. Are you saying, and kind of creasing the wheel a little bit, if I will, but are you saying that that type of a conclusion or that kind of a supposition is improbable?
Well, we all know that if you've got a deep pocket between the upper first and second molar, and you take out that second molar, the tissue is going to shrink down. If you've got a furcation involvement, you've got access to instrument and all like that. And there's certainly nothing wrong with the first molar occlusion, because with the premolars, 10% of the chewing is done with each one of those, and 60% is done with the first molar, and only 20% was done on the second molar. So extracting that second molar is not the wrong thing to do, but don't you think that ought to be the patient's decision? And you can offer to take it out, or you may treat that, and let's say you've got a 9 or 10 millimeter pocket, and you can get it down to a 5. Now, if 25 years later, that remains a 5, there's no bleeding on probing, there's crestal density on x-ray, would you take out that second molar then? But the patient has had the opportunity of having a full occlusion for those 25, 30, or 40 years. And I think this is something that all mature periodontists are aware of who've been in practice for many, many years, including you.
Right. So you've had the opportunity of observing that very situation.
Exactly.
Were there times when you electively took out second molars?
I really didn't, because I accepted the case as a challenge to try to treat any functional tooth. Now, I'm not saying that was a practical way of doing it, but that was just my philosophy. Just like you said earlier, for a year, you were not going to do surgical treatment. I decided if the tooth was not mobile, it was functional, and the patient was chewing on it, I would give them the opportunity of treating it. Now, I didn't have the opportunity of having this information, but the expression that I used to him, I said, Mr. Jones, you got a real bad upper second 12-year molar. If you want to roll the dice with me, I'll roll with you and see if we can save that tooth. Not a single patient ever decided not to roll the dice.
And from your perspective, you had the opportunity to observe every 3 months or every 6 months of your alternating recalls.
That's exactly right. That's exactly right. And the thing is, this was a way of educating the referring dentist as well, because they assume, well, this is a 7 millimeter pocket, that tooth needs to come out. But if it doesn't bleed, it's got crestal density, it is not mobile, and the patient is functioning on it, should they not have the opportunity to decide to treat that rather than take it out?
Sure, sure. And yeah, the older you get, the more you decide that observation may be the best treatment.
Right. Well, let's speak to the audience listening to this.
Yeah.
If you are 60 years old and you have got an upper second molar that's got a 6 millimeter probing depth between the first and second molar, the tooth is stable, there's crestal density, there's no bleeding on probing, are you going to ask the dentist to take that tooth out? Yeah. I guarantee you I'm not.
That's right. That's right.
But that's what I refer to as a periodontal defect, not a periodontal pocket. And we're not going to discuss it this time, but using a water irrigator with a sodium hypochlorite rinse in it, which will probably get down into the probing depth 2 or 3 millimeters, you can kind of keep that area bacterial free.
Very good.
Now, of the 641 molars that survived, nearly 90%, 87.6, met the AAP criteria for survival and health. So no, I was not maintaining disease. I had created a healthy situation. Here are the results from the Cox proportional hazard model. And each of these lines represents a score. The top one is a 1. I think the bottom is 11 or 12. And it shows the individual teeth on that. So if we go on the vertical axis and draw a line and then look at the percent on the left, we can see that a 1 has a 98% chance of survival for 15 years, and down here 11 or 12, which it is a 53%. So this is the scoring system that we have. If a tooth scores a 5, they've got a 93% chance of keeping the tooth in health for 15 years. And we use a little ditty on this that we share with our patients. If you want to keep your teeth alive, keep your MMPPI below a 5. Now, here's the score sheet, which you can find under resources on my web textbook. And you can see on the top left where the scoring is done. You can see in the middle of the page on the top where the percentage is done. The statistics talking about tooth loss, we want to keep the score ideally a 4.3 or less. The comment on smoking, the scores on the bottom center, but on the right are the keys to success, which I think needs to be shared verbally with all patients. And what do you see on the bottom? If you have family or friends that want to save their teeth, please share this with them because you're happy to see them. So letting the patient leave with their score sheet and maybe 2 or 3 others to share with family and friends is going to create patient referrals. The keys to success, let's look at them. You need to brush and clean interdentally on a daily basis. You got to clean thoroughly the posterior third of the tongue, for after cleaning the teeth and interdentally, 90% of the bacteria are left on the posterior third of the tongue. And these bacteria are basically sulfur forming and contribute not only to the number of bacteria in your mouth, but also to halitosis or bad breath. You've got to complete the recommended treatment. Well, duh, if you don't complete the treatment, then certainly it's not going to work. Adhere to the recommended maintenance schedule. Control your blood sugar if you're diabetic. Stop smoking, ideally, but at least cut back to, say, under 5 cigarettes a day. And also, we need to do some smoking counseling if the patient is a smoker. But here's what I want you to look at. Everything on this image is under the control and the responsibility of the patient. So we're not giving any guarantee on that. What we're telling the patient, if they will meet and comply with the keys to success, then they can have this level of success. If they don't, this prognosis scoring has no meaning. So what are the conclusions? Young people with moderate to severe disease can have an excellent prognosis if their disease is treated aggressively, and that means surgical treatment. But what do we do as dentists? We think they have a poor prognosis, so we give up on them. Smoking is the most significant factor. And finally, furcation involvement should not be used as a significant criteria for extracting teeth. And by eliminating furcations, as Dr. Chaslin and Dr. Milker have shown us how to do, we can even lower the score even more. The 7 factors that we talked about are here. But here's what's significant. These 3 factors, age, smoking, and diabetes, which are 3 of the 7 factors, can be scored before the dentist ever sees the patient. They can be scored by the dental assistant while the patient is in the reception area or as soon as they get in the chair. So therefore, let's say the patient scores a 1 on age and they're a smoker, they're already a 5, so keeping the PPI score below a 5 is going to not be able to if the patient is a smoker and the patient is not a diabetic. The patient comes in the chair, and now let's look at patient 1, which was very typical of the patients that I saw when I was in practice. This is a 42-year-old male. He smokes a pack of cigarettes a day and he's not a diabetic. So therefore he's a 5 before we start. The treatment-focused diagnosis, moderate to severe localized periodontitis in the molar area. This tells you exactly where the treatment is going to be done. We don't know from this diagnosis whether this case can be treated non-surgically or whether surgery is indicated. But certainly there's a possibility that this case could be treated non-surgically, and that would be the approaches you should take. We're going to score tooth number 15, which scores a 2. We score a 2 on probing depth because there are some 8mm pockets. And remember, this study was done before the term clinical attachment loss was a recognized term. If we were going to do a study today, we would use that rather than probing depth. The furcation involvement, the patient does have a mesial buccal, a mesial palatal distal buccal, and I am concerned about the mobility, so that tooth is basically a hopeless tooth if we don't do the scoring and give the patient a target to aim for, and in most practices that tooth would be removed. So therefore, if we look at this, he has less than a 50% chance of keeping that tooth under the current status. But let's go and give the patient a target score at that initial appointment to aim for. Age is going to remain the same. Let's hope he stops smoking. Patient is not diabetic. Molar type is going to be the same, unless he has Dr. Chaslin and Dr. Milker's concept where furcations can be eliminated. The probing depth is not going to be ideal. We're going to end up with some 5 millimeter pockets. But are they pockets or are they periodontal defects? If they are not red, there's no suppuration, and there's bleeding on probing, I think they are periodontal defects. And
Lee, tell them that typo there. There is no redness, there is no bleeding on probing, so therefore that's why I refer to them as a periodontal defect. I misspoke there, and I apologize for that.
I got it. Thank you.
would probably remain the same. We're going to reduce mobility, and what was a hopeless tooth now has a prognosis of a 7.
So look at the prognosis of 7. So essentially now you're showing the patient what you and he can do together in order to be able to improve that prognosis from less than 50% to 80, 60% over 15 years. Right?
Right.
Yeah. Now, I'm going to disagree with you. You mind if I disagree with you?
Oh, that's what it's all about.
Hey, you're saying these days I do clinical attachment loss. And I'm going to say, if you do clinical attachment loss, I'm not going to do this because it's too difficult for me to subtract.
Well, that is true too. And let's face it, when I was doing the exam, how long did it take me to chart a patient? A couple of minutes?
Right.
But I didn't get in there with a cow horn and try to say this is a class 2, class 3, class 4. I just didn't take the time to do that.
Yeah.
Because you really cannot classify what a furcation is until you got the flaps back or use your perioscope. And you may want to comment on the perioscope because, let's face it, the main reason I did surgery in those days, there were no lasers, there was no perioscope, and surgery was done mainly to get the mess off the root. Now comment on your perioscope.
Well, the perioscope, first of all, I can see better with a perioscope than I can see with flap surgery. If I do a flap, how am I going to look into the distal of an upper first molar? What am I going to do? Look around the patient's cheek or use a mirror in order to be able to see where the calculus is? When I use the perioscope, number one, it's non-surgical. Number two, it magnifies the root 40 times. Number three, I can put the scope where I need to see the root. It sees around a corner. And so I have the opportunity, or my hygienist has a better opportunity, in my opinion, of removing the calculus than I ever did when I was doing flap surgery.
That is true. And you know, the dental laser is very controversial. But from the data that I'm seeing and presentations that I'm seeing, people using the laser and people using the perioscope are saving a hell of a lot more teeth than those who aren't.
That's true. And a number of laser users are now buying the perioscope in order to be able to make the root planing more effective.
Great.
Yeah.
Let's roll it.
Good.
So therefore, rather than take the tooth out, if a tooth has a prognosis of 86% over 15 years, what would you do in your mouth? In my mouth, I would treat it. Patient number 2. Now let's pay particular attention to this because this talks about lifestyle change. This patient is a 29-year-old female. She's smoking 2 packs of cigarettes a day. So she is a 4 because, like I say, she's under 39. And the patient says that she's not a diabetic. But as we go through the health questionnaire and look a little deeper, and interestingly enough, she has no probing depths over 5. She has no attachment loss, either clinically or on x-ray. And really what she has is a severe, stinky, bleedy, generalized gingivitis. In all probability, I as a periodontist would never see this patient, but shows how impactful scoring can be by the restorative dentist. But let's look further. Her mother and 3 aunts are diabetic, which means that there is a significant gender-related problem here. The patient is significantly overweight, and the patient denies being a diabetic. So if they're not a diabetic, then you can use an in-office A1C score, which I mentioned earlier, which costs about $15, and you can get an accurate feel for the level of diabetes. But this patient says that she was not diabetic, but once we did the A1C score, she scored an 8.6, so we score a 3. So even though she has a gingivitis, she's already a 7. We're going to score tooth number 14, which is a 1. And remember, severe gingivitis, bleeding, irritated, sore. Are you going to do a complete in-depth periodontal exam on this patient, probing 6 places on each tooth? I don't think so, because if you do, you're going to hurt the patient and they ain't never coming back. So what you do on this type of patient is select like number 14 and do very gingerly probing on that, trying to get a feel for that so that you can come up with a score. And we got no probing depths over a 5, and but yet there was significant bleeding on probing. So therefore, probing depth is a 1, furcation involvement, no attachment loss, mobility, diabetic. And I want to emphasize here, if you do an A1C score in the office, under no circumstances, if the patient has not been diagnosed a diabetic, do you mention that. Because once you label a patient as diabetic, this can impact their job very negatively. For instance, you have someone in the construction building building a skyscraper up on scaffoldings and all, could very well lose his job, and you don't want that to happen. Simply tell the patient that they've got an elevated blood sugar and they need to see the physician, and let the physician make that. So therefore, even with just a gingivitis, the patient scores 11. But let's look at the impact that lifestyle change and periodontal treatment can have on this patient. The patient scores, as we say here, 11. So therefore, she barely has a 50% chance of keeping that tooth for 15 years. And so that would be a very discouraging diagnosis, and in many practices, that tooth would be extracted. So let's give her target score. She stops smoking. She gets her diabetes score down to a 7.1, not ideal, but much improved. Molar type remains the same. And certainly you should be able to get total pocket elimination of the gingivitis if we do the treatment and she follows what we ask. Still no furcation involvement. And by reducing inflammation and controlling the blood sugar, what's that going to impact on mobility? It's going to reduce that. So all of a sudden the patient scores a 3. Now how do they feel when they see they got a 96% chance of keeping their teeth for 15 years if they will do the things that they need to have done and do the things that they need to do for themselves?
Patient, stop right there, Lee.
This
stop
is
right there. Before we do patient 3, now what are we doing on that last patient? She's 29, she's overweight, she's heavy smoking. Can you imagine what her breath smells like? What is the likelihood of her being in a relationship, or if she's in a relationship, that it doesn't just go kaput? But let's think about it. She does the things we ask, she loses weight, her breath smells better, the chances of finding her a man becomes much greater. And so you can share these things with the patient, and this patient, once this information was shared, just absolutely floated out of the office, because we told her what she needed to do, not only to improve her dental health, but to improve her lifestyle. And that is extremely important and a real service that we can provide. Let's roll patient 3.
You see quite often in your practice a 75-year-old male who's a non-smoker. He's a diabetic but does not know his A1C score and has a treatment-focused diagnosis of severe generalized periodontitis. He has been to one other dentist and it's been recommended that all of his teeth be removed and an all-on 4 done. But let's look at it in depth. So here we see the factors involved. The age, over 75 is a 1. Patient is not a smoker. He says he's a diabetic, but we don't have an A1C score at this point, so arbitrarily we score a 2. We're scoring number 14, which maintaining in a 75-year-old a first molar occlusion may be a reasonable treatment plan. Probing depths are 2, which means that we're getting many probing depths in the 8 to 10 millimeter range, and we can see on x-ray this significant bone loss, and we can see why most dentists would give up on this case. But on that molar, he only has one furcation involvement, and I am slightly concerned about mobility, but not like I would be on a 29-year-old that had this level of loss. And I would probably score that a 2 or maybe even a 3 on the younger patient. But therefore, given all circumstances here, I'd score that a 1. But he only scores an 8. I say only an 8 because with an 8, that means that he has an 81% chance of keeping his teeth. And that certainly does make a mockery of the dentist that told him they needed an all-on-4. So let's talk about give him a treatment-focused diagnosis. Age is going to remain the same, but then he elects to have an A1C done, and it's even lower than they thought. It's a 7.1. Molar type's the same. We're not going to get ideal probing depth on this. We're going to end up, obviously, with some probing depth that's a little greater than 5. Furcation, unless there's root reshaping done by the Melker-Chaslin technique, we're not going to have a furcation. We're going to keep a furcation. And as I treat this and we get better control and so forth, mobility is not going to scare me. And looky here, we've got him down to a 5. And remember that.
Stop right there. Stop right there. We have not mentioned occlusion, but occlusion is very important. So therefore, on this patient, I would do some occlusal adjustment, ending up with just a centric stop, not having any working on it, or non-working, or protrusive interference. And so therefore, I think the tooth would stabilize, and that's the real reason that I would put a dash on there. Because at 75, if I wasn't particularly concerned about the mobility to start with, and yet that's reduced, you can see the rationale for putting a dash on that and getting him down to a 5. Let's roll it.
If you want to keep your teeth alive, keep your MMPPI below a 5. Now, what do you think this patient is going to think when he gets ready to leave the office? I was told I need to have all my teeth taken out, but I've got a chance of keeping my teeth for 15 years, 90-some%. What is he going to elect to have do? I think the average patient is going to elect to have his teeth treated.
I'll tell you, when I look at this, PD, it's something that I see all the time, and I'm sure most of our audience does as well. When teeth are badly carious and we have recurring caries, that's almost impossible to treat. When you have a patient who has periodontitis, that's easy to treat and predictable to treat. Yet out in the field, we're seeing a lot of patients who are having teeth extracted or recommendation for extraction because the assumption is, oh, you've got periodontal disease and therefore you're going to continue to get bone loss. You're going to lose your teeth. So we might as well do that now. And nothing is further from the, that's about as false as you can get. I can't tell you how many people's teeth we can save. And you're demonstrating this.
Well, for instance, as you pointed out, you get a 40-year-old patient with a deep overbite that's going to have an all-on-4. How much bone, alveolar bone, if you're removing the bone, how much bone are you going to have to remove?
I have to remove a ton with that kind of an overbite because we have to create a closer to a class 1 occlusion. And in order to do that, I've got to do a ton of alveolectomy in the upper arch. And
but what is the likelihood of them having peri-implant health for another 40 years? And what happens when they lose that with the continued bone loss? They're in one hell of a mess.
Yep. Particularly in the periodontal case. You're right.
Yes.
Right, yeah.
Okay, rolling.
Because here's the 5 that we're talking about. So what are the objectives of the clinical application? To motivate the patient to accept and complete treatment, to create patient referrals, to simplify the scoring so that it takes no time from the dentist, and to train staff to do the scoring for you. And also, we talked about the importance of smoking. Look at the tape. Counsel if you want to take the time to do it, or refer the patient to 1-800-QUIT-NOW. Is the patient guaranteed this level of treatment? The answer is no, because this is not a promise of success, but a guideline that leads the patient and enables them to succeed. The patient assumes 100% of the responsibility for success, and the dentist assumes no responsibility. Because here are the keys to success again: brush and clean interdental daily, clean the posterior part of the tongue, get rid of that halitosis, complete the recommended treatment, adhere to the maintenance schedule, control your blood sugar if diabetic, stop smoking or cut way back, and do some smoking counseling if they do. So the positive impact that it has on your staff and why they should be the scoring, and I think if you're going to incorporate this into your practice, you need to have them buy into it and do this at a staff meeting, because the assistants and the hygienists become a more integral part of the team. This adds prestige to their job description, and what does that do for morale? It increases morale. They become a more integral part of the team and much more important in the eyes of the patient. So you will find that patients will turn to the dental assistant or the hygienist and ask them questions that previously they asked you.
And really, when we're going direct to public, which, as you know, we're recommending, you're going to see a lot more patients. And therefore, you need to be able to utilize your staff to do what some of you are doing already. You know, we're seeing our patients for 2 hours in the office, but only a half an hour of that is my time. Well, the only way that occurs is if the assistant takes full responsibility for the case. And you've heard me say this before. You know, we're taught that assistants can't diagnose. And the answer is, my assistants better be able to diagnose. Because if they can't diagnose, then, or if they don't want to diagnose, then they're taking less responsibility for the patient. Yes, the doctor is responsible for the final diagnosis. We're not arguing that at all. But in terms of responsibility, we want the assistant to take the utmost responsibility for the patient, because then the patient has the confidence to ask the assistant the questions, and I can leave the operatory because the assistant already knows the answer. Well, this is one tool which allows the patient to understand that the assistant knows what's going on and allows the assistant to communicate.
And I have a colleague in Charleston who is in his late 60s, beginning to slow down, and he was seeing about 25 new patients a month. The first month he used this, he saw 28. The next month he saw 32. The next month he saw 36. And of those 36, 2 of them were self-referred, which he had not had a self-referred patient in a long, long time. And now he has dentists calling him up that he has never worked with and say, I hear you're the periodontist in the Charleston area that saves teeth. I'm going to send you a patient.
Yeah. Isn't that nice and inexpensive marketing?
All right, let's roll it.
The additional positive, and this I think fulfills the moral and ethical responsibility in treatment planning. For I think once you've seen this, if you don't incorporate it in your practice and you don't share this information and you take out teeth, that would test my conscience. I think in the future we're going to be required to present this type of treatment option to the patient by the HIPAA changes and things like that. So here are our conclusions as we wind up. Scoring markedly motivates the patient to accept treatment. It's fast, simple, and easy to do. It increases referrals from patients. It proves that many teeth that we initially thought were hopeless are in fact treatable, and proves finally and definitively that furcation involvement is not the sole goal that we should use in extracting teeth. Now, Dr. Sheldon has been using this system for several months now, and I'm going to turn the program over to him and let him share his experience, and then I'll be happy to answer any questions that you might have. Lee, it's all yours.
Very good, PD. Thank you. Let me get the shared screen off and let's get back on the screen. Do we have any questions? I don't see any written questions here. So I think a lot of the questions we discussed during the presentation. Anything else that you think we should cover before we close?
Well, there's one thing that you mentioned when we were doing the rehearsal on this is the general dentist or the restorative dentist sends you a patient that based on the scoring, the tooth can be saved, but he has sent the patient to you to extract and do an implant. How do you handle that without making the restorative dentist look like he's inept? And here's a little story that I told you. There's nothing like a personal phone call. Call that dentist up and said, you know, you wanted me to take out number 30, and under conventional thought, that was a good idea on your part. But I just saw a video on saving teeth, and did you realize if you will let me treat that tooth, it's got an 87% chance of surviving for 15 years. Let me give you a website to look at and a link to look at, and how about us getting together? Perhaps I can come by your office or you can look at it, and let's look at it together and let's start saving more teeth. What do you think, my friend?
Yeah, kind of difficult to say no to that one, isn't it?
Yeah.
And you've got a convert. And
well, and also too, we need to have more personal contact with our referring dentist. You know, we email, we send text messages and all, but there's nothing like a personal voice phone call, which takes, in this particular case, how long did that conversation take? A minute and a half.
Sure, sure. Fantastic material, PD. And listen, let's understand what periodontists do for a living. We save teeth. It doesn't mean we can't do implants. We do implants. And we do a lot of implants in our practice. But it's the options that we give as periodontists that none of the dental implant clinics can give. And this is just one more way of educating your patients, letting those patients educate their friends, and educating your referring dentist as to what we can do for our patients to help them save their teeth. PD, fantastic material.
In closing, I'd like to say this. On the web textbook, there's a very short video on how to get started with this. And basically, it's about a 30-minute webinar that any dentist can use during a staff meeting, because we have got to engage the staff. And once they get on board, they will implement it for you. And all you got to do is get on that roller coaster and ride.
Yeah, very good. And give that web textbook address again.
pdmillerswebtextbook.com, all small. The S does not have a comma after it. And when you click on it, it has these videos on there. I think there are 32 of them now. And the beautiful thing about it is once you click on it, you can hear it, but you don't need to take notes or anything because it's always there if you want to go back to it. It's so much better than a textbook, because if you write a textbook, you've got to have a new edition, and by the time you get it published, the data is obsolete. With this, if something new comes out, all I got to do is to redo the video, which will take me maybe 25 or 30 minutes. So this is a dynamic concept, which I think is going to be a marvelous teaching aid in the future.
That's terrific. And I've got a comment already. Thank you both for this presentation. I love the hope that this gives both the clinician and the patient renewed hope of saving teeth. That comes from one of our members.
That to me is worth the whole deal. Hugs and kisses to that person.
PD, thanks for everything. I really appreciate it.
Have a good evening.
Thanks. You too. Good night.